the occupational therapist in occupational therapy is not explicit. It is unfortunately true that occupational therapists practicing in this field in South Africa places emphasis during both the assessment and treatment of hand-injured clients on aspects of body function and structure, such as range of motion and strength. This practice or occurrence is a double threat. Firstly, to the client, as stated by law and Baum, no one else has the expertise and emphasis on occupational performance. The result may be that the client must fend for himself or herself with occupational dysfunction that will compromise his or her function in participation and health. And secondly, there is a threat to the occupational therapy profession in an environment that is increasingly calling for us to demonstrate outcomes and the effectiveness of our intervention for increased resources and funding purposes. We do, however, find ourselves in what I've referred to as our multiverse, and the nature of hand injury intervention requires careful consideration of aspects of body function and structure. But the call is to not only focus on body function and structure and outcome measurement, that the occupational therapist practicing within this field takes an holistic approach and addresses it all. Now that we have established what it is that we have to measure, it is time to unpack the key concepts underpinning measurement. Measurement refers to the thing that is used during assessment, as well as potentially during evaluation of the outcomes. The measure, sometimes referred to as a test, the tool, or the instrument, usually has some form of instruction, has a unit of measurement that can either be time or centimeters or a score, and has a specific way in which it is executed and documented. Assessment and the evaluation of outcomes, to me, is understood by considering one as measuring the process and the other as measuring the outcome. In considering the process assessment, also sometimes referred to as formative assessment, these are the measurement activities that are carried out towards gathering information about the client to get a comprehensive picture and plan treatment. It may involve several methods and several sources, and could involve informal and or standardized assessment. This is also carried out in a number of time intervals during the occupational therapy process. The therapist may also use this in action in order to adjust treatment offered. Evaluation or outcome measurement is done towards establishing the end result or to evaluate how things went, thereby evaluating the outcome of the intervention. It requires interpretation of the measurement. As a result, this has to be done at least twice, and an essential requirement is that it should be able to evaluate change. These measures are required to have robust measurement properties evaluated in context, including but not limited to validity, test retest, reliability, and responsiveness to change. Outcome measures provide the much needed evidence of the effectiveness of the occupational therapy intervention, and as a result should address all the aspects as outlined by the ICF and not just aspects surrounding body function and structure. Assessment during hand injury care should fit within a specific framework or occupational therapy model. It should address all components of said framework or model to convey the unique contribution of the occupational therapist within this field. And it should consist of assessment activities that address both process assessment, how things are going, and outcome measurement, evaluating how things went. So the recommendations therefore include the provision of educational opportunities to novice occupational therapists, unpacking the concepts assessment, evaluation, and measurement, ensuring occupational therapists have a basic understanding of the measurement properties of instruments and the importance of contextual evidence of these properties, to introduce the various types of measures based on scope, and provide a rationale for choosing the correct one, administering it appropriately, and utilizing the results as intended. Our assessment practices in the field reminds me of the analogy of a tree falling in a forest. If a tree falls in a forest and no one is around to hear it, does it make a sound? It always reminds me that if there is nobody to witness it, then it is as good as if it didn't happen. and therefore there is no evidence of the tree making a sound. In this analogy, the sound is our evidence of robust assessment and outcome measurement. We must be sure that there are people there to witness it so that there is never a question about our value and contribution to our patients and the field of hand therapy. Thank you very much.
Okay, I think very different from the other presentations. It is very theoretical, but that is something that interests me a lot. So in mental health, I am the Susanne de Klerk, what Susanne de Klerk is for hand therapy. So outcomes very important. Okay, so thank you, Susanne. Then the next one is how can outcome measures inform hand injury rehabilitation in a specialized hand therapy unit? And that's going to be Nicole Mati Bisram, and she's from Chris Hani Baragwanath Hospital, also online.
Good morning. My name is Nicole Mati Bisram. I'm an occupational therapist currently working in a specialized hand unit at Chris Hani Baragwanath Academic Hospital. Today, I will be presenting on how can outcome measures inform hand injury rehabilitation in a specialized hand therapy unit. An overview of my presentation, I will give you some background information, explain how the monitoring and evaluation system developed, and then looking at the system that we implemented both for flexor and extensor tendon repairs that included outcome measures, and how we use the results from these systems to make changes or adaptations in our approach to tendon repairs. And lastly, I will go over some recommendations that may be beneficial for therapists as well as novice therapists that are currently working with hand therapy. So when one looks at an outcome measure, it is a tool that is used to assess a patient's current status and to monitor progress. It also reflects the impact of the healthcare service or intervention on the health status of patients. So we know that outcome measures are an invaluable tool that can be used to monitor patients' progress throughout their rehab journey. So Baragwanath Hospital is considered the third largest hospital in the world. We have approximately 3,000 beds, of which 220 beds are allocated to orthopedic cases. We have a specialized hand unit, and in this unit, the top diagnoses treated by occupational therapists are both flexor and extensor tendon repairs. This dominates the load with an average of 150 sessions per month. So how exactly did this monitoring and evaluation tool develop? We looked at our departmental planning and evaluation in 2018, and the aim of it was to develop a tool within each subsection to analyze a service or evaluate a service to determine if it was effective or not. The orthopedic subsection had chosen flexor and extensor tendon repairs, and we moved on to developing an M&E form that included a lot of research and evidence to find a form that would be quite comprehensive. We then developed an Excel database, and on this, all patient information was captured, information was coded and de-identified, and descriptive stats was used for analysis. We then looked at a reporting structure where information was then reported on every quarter in our operational plan, and we also looked at then the actual data that we collected together with clinician experience and observations, looking at how we could adapt our rehab protocol in order to improve rehab services. So the M&E system for both flexor and extensor tendons included patients that were 18 years and older. It included all zones but excluded the thumb. We looked at the nature of the injury as well as the surgery that was conducted. We also looked at the protocol that was followed, and we took goniometric measurements as well as grip strength measurements. A quick dash was done for both flexor and extensor tendons, but one difference in one of the outcome measures was that we looked at TAM for flexor tendons and Miller's criteria for extensor tendons. An overview of the FTR results. So we predominantly had males that were affected at 75%. Between 18 and 30 years was the top age band that was affected, which was 46%. And most injuries were related to injury acquired, which was 57%, and violence related, which was 36%. The mechanism of injury was glass and knife, with each at 25%, which was then followed by machinery-related injuries. Furthermore, we had predominantly FDPs and FDS that was involved, and a high incidence of ulnar nerve injuries. And the two common zones that were involved was a zone 2 and zone 5 injury. 89% of patients had a 4-strand repair, and 88% of patients followed the early active motion protocol. 3% of patients had a primary repair, and this is also due to the nature of the intake of patients and availability of theatre time and beds. So 69% of patients had a delayed primary repair, which is still acceptable. In terms of TAM, 76% of patients presented with fair to good outcomes, and this was based on TAM. Their quick dash scores improved across weeks 4 to 12, showing functional improvement throughout the rehab process. So changes in our approach in managing these patients. We looked at the adherence of therapy. So only 20% of patients had full adherence to therapy throughout the rehab process. Some of this was attributed to contextual factors, such as obligations to work or finances that were limiting, as well as distance to the hospital. So with that being said, we still wanted to focus a lot on patient education, so that if a patient, for instance, still was unable to attend an appointment, we knew that if they understood their exercises well enough, they could continue their therapy at home until they were able to attend the next appointment. So we looked at being big on education, which was done previously, but we looked at reiteration through every single appointment so that patients had a very good understanding. We also looked at local clinic training. So patients had to be referred out between weeks 8 and 12, and that's due to high patient loads. We wanted clinic therapists who often rotate, quite frequently, to understand when patients needed to be referred back to the unit so that they weren't lost in the system. So, for example, patients that may need a neurolysis, a tenolysis, or a Hunter's rod reconstruction was then referred back to the unit and not lost in the system. We continued with our basic splinting training that was open to the entire province, and we just reiterated a lot of cluster support. We've recently asked clinic therapists to come and observe us on days that they are available or on conditions that they want to gain more confidence in. When looking at the zones that were affected, so we predominantly treated zone 2s and zone 5s. And with the zone 2s, we tried to propose a Manchester splint, but it requires some buy-in from the doctors in order to administer a wallet. We found quite a lot of PIP joint contractions. So we used a tongue depressor in order to improve extension of these joints within a protected range. And we also changed the splint so that we could allow more wrist tenodesis for our zone 5 injuries for patients to continue with that work. From clinical observations, we needed to start edema management a lot sooner. So we looked at circulatory drills, elevation, and co-band bandaging, as well as ensuring that exercises started at day 4 to give time for edema to subside. With our zone 5s, we found a lot of adherence scars. So we introduced the use of Dyson. We started using coconut oil for scar massage, which we would then issue to patients. And we continued with Sikaki and pressure garments and tried to do more kinesiotaping for the very stubborn adherence scars. With our ETR results, again, it was predominantly male with 80% of male involvement. The top age band was between 18 to 30 years, which was at 44%. And the cause of the extensor tendon involvement was predominantly related to violence at 58%, and 40% was related to injury. When one looked at nerve involvement, we just had one patient that had an ulnar nerve involved. 63% of the cases were uncomplicated, and we followed an early active motion protocol for 56% of patients and an ICAM protocol for 29% of patients. So predominantly our EDC was involved and zones 5 and 6, and again predominantly it was delayed primary repairs. So results with our extensor tendons, and this was based on Miller's criteria. We had 80% of patients presented with good to excellent outcomes, and flexion loss, however, was a concern, with 61% of patients presenting with fair to good flexion between weeks 8 and 12. Our quick dash scores, again, you can see that from week 6 to week 12, the scores are improving, which shows that functional outcomes are improving across the rehab process. So what did we do when we looked at changes in our approach? So with these patients, we found that 21% of patients adhered to therapy throughout the rehab process. And again, we look at reiteration of patient education as well as local clinic training. We started introducing more relative motion splinting for central slip repairs at week 6 post-immobilization. And we also introduced pop casting for those stubborn PIPJ flexion contractions. We looked at muscle belly repairs that had to be immobilized first for 2 weeks before introducing splints and exercises, because we found that we experienced a lot of extensor lags with our muscle belly repairs. And when it came to the flexion loss, we looked at increasing the MPJ flexion in the splint and increasing wrist extension to try to counteract the MPJ extension contractions that we were experiencing. We also looked at static progressive splints from week 8 to increase composite flexion, and we would then increase the period of immobilization for muscle belly repairs if there was an extensor lag present, however, in the absence of joint stiffness. And we continued with the same principles for edema management and scar management as we did with our flexor tendon repairs. So recommendations from this is that we found a monitoring and evaluation system that included outcome measures helped guide treatment decisions, but this had to be done in collaboration with clinicians' observations as well as their experience. It helped us review protocols to suit our patients' context as well as our capacity and ability to see patients. It helped us identify the need for cluster support and training, especially as a central hospital. And it also helped with assistance with patients to adhere to therapy, because as we monitored their progress, the patients could also look at where they were at through the progression of their rehab. It also allowed us to have more collaboration with hand surgeons and to give input on adaptations to surgical techniques that then allowed us for implementation of different rehab protocols. So thank you very much for your time, and I hope that this information was beneficial, and that moving forward we start looking at more outcome measures to ensure that we monitor our patients' progress through rehab very closely, but also to motivate and showcase the effectiveness that therapy or occupational therapists offer in the field of hand therapy. Thank you.
Okay, I think that was brilliant. So moving on from Susan, who explained the outcomes, what is an outcome measure, and this setting, applying it and showing the effect on their practice. And that is also generating their own evidence of their services, which is fantastic. Okay, so next is another online, but now you need to move yourself to Australia, because it is Rosie Gospel from Australia who's going to talk about the complex regional pain syndrome, early identification. Thank you.
Hi, my name's Rosie Gospel. I'm an occupational therapist and a hand therapist, as awarded by the Australian Hand Therapy Association. I run Compassionate Hands for CRPS, which is a telehealth business for people with complex regional pain syndrome, CRPS for short. And today's presentation is on CRPS and how you can identify early, and some guiding principles behind some OT treatments. Dr. Norman Harden is highly regarded in the CRPS world. He has teamed up with 6 other MD and PhD doctors, and all experts in CRPS, and they've reviewed 406 articles on CRPS. From this, they published a practical and diagnostic treatment guideline in the journal called Pain Medicine last year. This document is online and free, and I'll be referring to this heavily. Harden et al. Write that type 1 and type 2 CRPS is only a historical distinction, as the clinical features are identical. However, these 3 subcategories are very helpful. Number 1, a relatively limited syndrome with vasomotor signs predominating. This person might only have some discomfort or very minimal pain with movement, for example, but there might be lots of temperature differences, unusual stiffness and trophic changes. Number 2, a relatively limited syndrome with neuropathic pain sensory abnormalities predominating. This person might only have mild intermittent temperature or skin color changes and less stiffness, but have more allodynia, hyperalgesia and neuropathic pain. Number 3, this is the worst one, a florid CRPS syndrome with a wide array of CRPS features. There is also to be a new CRPS subcategory included in the latest ICD-11, which is CRPS with remission of some features. Another useful subclassification is between cold or warm CRPS, as they respond differently to some treatments. I think it's really important to point out to patients that CRPS is not a disease, and hopefully this can be reassuring to hear. It is a syndrome, or a combination of signs and symptoms that is diagnosed clinically through objective and subjective assessments, using the revised Budapest diagnostic criteria for CRPS. As with any other syndrome, there is a huge amount of individual variation. And there's a continuum from what I think of as a bit CRPS-y that resolves within a few weeks, through to the other end of the An OT treating a hand injury could be the first person to identify early signs of CRPS and take steps towards early resolution. Many authors comment that early intervention is a crucial aspect for a speedier remission. This hand here is the most common presentation I find. The colour is often mottled and darker pink-purple or red compared to the other side. This looks like a warm CRPS, which is by far the most common, and average recovery for warm CRPS, according to Harden et al., is 4.7 months. This is a cold CRPS, which is often paler, blue, white or purplish. Average duration is 20 months, but there is a rare group of cold CRPS with a very short duration. Warm CRPS, if not resolved soon enough, will often progress to cold CRPS, which is harder to treat. Edema in CRPS is neurogenic and can therefore be excessive and persistent. Hair growth in the area might be darker or coarser. Joint stiffness can be mild through to extreme and involve joints that weren't directly involved with the initial trauma, if there was one. Nail growth can be faster or slower, or the texture of the nail can be different. You must compare to the other hand. Here you can see the difference in skin colour between the two hands next to each other, but it might be easy to miss if you only looked at the one hand. This is an X-ray of the same patient showing widespread osteopenia in just the CRPS affected hand. This is a common finding in CRPS. This slide demonstrates the large quantity of possible differential diagnoses for CRPS, some of them dangerous to have a delay in diagnosis, such as infection. These can also be concomitant with CRPS, which is why we as OTs play an important role in early identification of signs and symptoms, but a doctor needs to make the diagnosis. This is a copy of the revised CRPS criteria. It has a sensitivity of 0.85, which captures most CRPS positive cases, and a specificity of 0.69, which is better than most objective tests. The 4 categories include 1. Continuing pain which is disproportionate to any inciting event. Of course, this is hugely subjective, and remember, it could be a relatively limited syndrome with only minimal or even no pain in my experience. Number 2, at least one symptom in 3 or 4 categories. 3, at least one sign in 2 or more categories. And 4, no other diagnoses better explains the signs and symptoms. Harden et al. Write that inappropriately aggressive PT can trigger extreme pain, edema, distress and fatigue, and may in turn exacerbate the inflammatory and sympathetic symptoms of CRPS, and is therefore to be avoided. This stepwise treatment approach is recommended. If symptoms are flaring up at a certain level, it is best to try the patient at a lower step until they are ready to progress up. For some people with CRPS, just watching someone else move, step 2 on the ladder here, can be enough to cause a flare-up, and they might need to start with 2-point discrimination training. Here is a link for more information on 2-point discrimination training. For more information on steps 3, 4 and 5 of the ladder, there is a summary in this free poster available at this web address. Number 6 on the ladder was gentle active movements. An appropriate level of nerve mobilizing exercises is a good idea for CRPS. An amazing method for assisting movement is serial casting of the PIP joint, or paradoxically to immobilize some joints using plaster of Paris and encourage lots and lots of active movement of the stiff joints. This technique is called casting motion to mobilize stiffness, or SIMS for short. The circumferential padded casts combined with active movement gives a lymphatic massage and can resolve even high protein persistent edema. The casts correct poor movement patterns and in my experience are more effective than anything, including dynamic splinting, for overcoming even the most stubborn and prolonged stiffness. I learnt this technique from South Africa's own OT and hand therapist Robin Midgley in one of her online courses. SIMS is cheap in terms of materials and requires less contact between therapist and client, as they can wear each cast for up to a couple of weeks if they are a rural patient, before possibly needing it changed to a different style of cast that targets different joints. Steps 7 and 8 on the ladder are for patients doing well with active movement. OTs can then start teaching pacing skills. In CRPS, there is dysregulation of the autonomic nervous system at the level of the limb, but also at a whole organism level. OTs are trained in relaxation and can use these tools with CRPS patients. And what's that saying? Prevention is better than cure? The study by Gillespie et al. Found that with a few simple strategies, they reduced their incidence of CRPS type 1 postdistal radius fractures from 25% to 1%. Some of these strategies included changing too tight casts, only immobilizing joints that really needed it, for example, leaving the MCP joints fully free to move, and encouraging movement of the uninvolved joints, light activity, and attention to the limb while in the cast. Thank you for listening, and thank you for this opportunity to work towards early identification, prevention, and treatments for people with CRPS.
Back in South Africa, so just switch yourself back here, is examining wound management in South Africa, and that's Lizanne Estreisen and Adeshni Naidu and Pragashni Govender.
Hello, my name is Lizanne Estreisen. Thank you for the opportunity to present my master's research examining wound management in hand therapy within the South African context. Internationally, it is within OT scope of practice to provide interventions for the prevention of wounds, the amelioration of wounds, which is geared towards wound healing, and to address occupational dysfunction resulting from wounds. The skill of the OT is their ability to analyze and understand the impact that an acute or chronic wound has on an individual's functioning and their ability to participate in meaningful occupations and fulfill meaningful roles. Individuals with upper limb injuries are at risk of and frequently present with wounds. Internationally, wound management is recognized to be within the scope of practice of therapists providing care to hand-injured patients. In South Africa, there is an expectation for OTs to provide hand therapy services to individuals with complex upper limb injuries, including interventions related to wound management. The problem is that OTs may not have received adequate undergraduate education and training in the field to cope with such demands, and the role of occupational therapy in wound management is not clearly articulated within the South African scope of practice. The study aimed to describe the current practices of OTs in providing wound management interventions to hand-injured patients in the country, the views of practicing OTs of their role in wound management within hand therapy, and their level of preparedness to manage hand wounds. A cross-sectional survey was administered. Non-probability convenience sampling was used to recruit OTs who, at the time of data collection, were registered with the HPCSA, were practicing in the field of hand therapy, and who had obtained the majority of their experience in hand therapy in South Africa. Data collection occurred between May and July 2020. A total of 106 questionnaires were eligible for analysis. Participants were mostly female, between the ages of 26 and 40 years old, and were mostly working in private settings. The table on the right shows that 39.6% had postgraduate qualifications in hand therapy and 60.4% did not. The majority of participants had 6 or more years of experience in hand therapy. They mostly came from Gauteng, KwaZulu-Natal, and the Western Cape. Between 50 and 100% of patients with hand injuries treated on a monthly basis were reported to present with wounds by 71.7% of participants. 73.6% of participants encountered wounds at least weekly or almost weekly, with 31.1% encountering wounds weekly or almost weekly, 25.5% encountering wounds daily, and 17% encountering wounds several times a day. The traumatic nature of injuries for which patients receive OT in South Africa may account for this high prevalence of wounds. In addition, OT frequently commences within the first few days post-injury or surgery, and this may also contribute to the frequency of encountering wounds. 94.3% of participants did experience a demand to be involved in wound management, and 5.7% of participants did not. When looking at the reasons for the demand experienced by participants to be involved in wound management, 84% agreed that it was more convenient for the patient if OTs includes wound management as part of holistic therapy. 85.8% agreed that patients follow up more frequently with OT. Routine and frequent care is substantiated by the intensive nature of hand rehabilitation required for functional recovery. Participants also provided qualitative reasons for the demand that they experienced to be involved in wound management. This included that they frequently received referrals for diagnoses requiring wound management. They expressed concern for preserving the patient's time and finances. They indicated that wound management frequently was needed prior to splinting and mobilization. They also showed concern for the functional implications of wound healing and the impact of scar tissue. They indicated that wound care professionals are not available in all settings between specialist consultations, and that patients do not always follow up with the surgeon. The frequency of managing wounds was found to be very similar to the frequency of encountering wounds. And when comparing the results of this study to those of international studies, it was found that wound management interventions were more frequently provided in South Africa than in other countries, and this could be attributed to the higher rate of trauma within the country. The study looked at what it was that participants did when they provided wound management interventions, as well as how frequently they provided these interventions. Participant feedback highlighted that scar management, followed by wound assessment, applying dressings, and cleaning wounds were the most frequent interventions provided. Internationally, these were used in the same order of frequency. Interventions for the prevention and amelioration of wounds were found to be more frequently provided than interventions facilitating participation in meaningful occupations. This reiterates findings by other authors, implying a lack of focus on occupation in hand therapy intervention. When looking at the way in which OTs worked with other members of the MDT for wound management, it was found that OTs were infrequently the only team member responsible for wound management. When working with other members of the MDT, participants reported that they most frequently request dressings that allow movement, educate on protecting healing structures when doing wound care, educate on applying dressings for splints to fit. They consult and advise for more complex wounds and refer when there is an issue of concern. So interactions with the MDT were often directed at ensuring positive surgical and rehabilitative outcome. The majority of occupational therapists agreed with the descriptors listed when considering the role of OT in wound management. One participant disagreed with all descriptors listed, and the remainder remained neutral. OTs agreed that they had a role to play in treating hand wounds as part of holistic intervention, providing a supportive role in the management of wounds, providing sensory education to prevent wounds, educating patients on wound management, monitoring and referring for issues of concern, monitoring the progression of wound healing, providing environmental adaptations, providing adaptive techniques, facilitating ongoing employment, enabling participation in meaningful occupations, and understanding the impact of a wound on function and participation. Participants also qualitatively stated that they have a role to play in applying dressings that avoid poor positioning and allow for splinting as well as functional mobility of the hand, monitoring the wound for the early detection and prevention of possible complications, and having an understanding of how a wound may impact treatment planning. The findings of the study revealed that OTs identified their role in the provision of interventions as addressing body functions and structure elements and addressing activity limitations and participation restrictions. However, the results revealed that when looking at what it was that occupational therapists actually do in practice, that interventions were more frequently geared towards addressing body function and structure impairments. The study found that there was a trend towards the acquisition of wound management knowledge and skill to happen within the first 2 years of practice in hand therapy. This reiterates international findings. However, it emerged that wound assessment, scar management, the use of pressure garments, and identifying signs of infection, the phase of healing, and delayed healing were to some extent covered at an undergraduate level. This is in line with the minimum standards for the education of OTs. When looking at the influence of previous training and experience on preparedness for practice, it was found that undergraduate education in terms of theoretical training somewhat prepared just over half of the participants. Undergraduate practical fieldwork experience, however, did not prepare 60.4% of participants, possibly indicating that there is a need for review of practical fieldwork experience within undergraduate education. The factors that did contribute to increased preparedness were clinical experience, observing and working alongside more knowledgeable professionals, and mentorship. These findings are supported by local and international studies. 98 to 92.5% of participants agreed that including basic wound management in undergraduate training is required. The majority of participants, 98.1%, also agreed that wound management courses aimed at OTs treating patients with hand injuries would be beneficial. They also qualitatively reiterated that more in-depth wound management training is needed at an undergraduate level, specifically relating to hand injuries, and stated that therapists should be prepared for their first year of work during which they may be exposed to wounds without access to mentorship, especially in rural placements. The unpreparedness of newly qualified OTs for hand therapy practice has previously been documented by other South African authors, and the results of this study reiterate those findings. The frequency of encountering wounds and the demand that OTs experience to be involved in wound management has highlighted the need for improved education and guidance on the role of occupational therapy. The apparent lack of unpreparedness for wound management in undergraduate education is compounded by poor articulation of the OT's role within the South African scope of practice. OTs also do not readily have access to CPD courses addressing wound management. Even though it's not feasible to equip undergraduate students with all the skills they may need for practice, OTs need to be provided with clear guidance on their role and scope with regards to wound care and hand therapy in the country. This may assist in improving the confidence of OTs to seek opportunities for professional growth and development, and to advocate for the unique contribution of the profession within an MDT approach to the treatment of patients with hand wounds. There are limitations of the study that need to be considered. These include that the sample was skewed towards occupational therapists working in private practice settings. Examining wound management practices with a sample more representative of public health management may therefore be required. Self-selection bias may have skewed the results of the study, as individuals who more regularly encounter wounds in practice may have been more likely to respond, and the results of the study should therefore be interpreted with caution and are not generalizable to the entire population of OTs treating hand-injured patients in South Africa. I have provided a list of references used within this presentation, and I would just like to end up by saying thank you very much for your time and for listening to my presentation.
Thank you, Lizanne. So that's also for us in education to take note of. Right, the next one is flex tendon rehabilitation protocol used amongst occupational therapists in South Africa. Jani Venter and Ansel Prinsloo. So this is also online. So are you still awake?
Thank you for the opportunity to present my master's research at this conference. My name is Jane Venter. My research was aimed at investigating how therapists in South Africa treated flexor tendon injuries and how satisfied they were with the outcomes. 32 therapists responded, and as you can see from the graph on the left, just over half of them had more than 10 years experience. Many had done various additional hand therapy specific training. So, what protocols are available? The list is extensive, and thus it is unfair to expect all therapists to be competent in all the different regimens, as they are called in research, especially newly qualified therapists. Traditionally, protocols have names such as Kleinert, Duran, and the like, but in the Cochrane Review published last year, they named each regimen by the action required. They compared efficacy of various regimens, and I'll discuss that later, but I took a screen grab to show you the diversity we have available. Early active flexion plus controlled passive exercise regime, which is something that might be used in the splint on the left. Early active flexion with active extension exercise regime. Mobilization regime, an early place and hold progressing to tendon gliding exercise regime, a passive flexion and active exercise regime, such as the splint in the top, and so on. There are many to choose from, and there are a mouthful to say. As expected, the majority of my research respondents splinted dorsally and used a static type splint, with just over a quarter using dynamic splinting. I compared experience levels with the choice of splint type. And what was interesting to note was that the more experienced therapists used dynamic splinting in isolation or in combination with static splinting. A take-home point here is it's really okay if you're a junior therapist to use only static splinting if you feel more competent in that area. This graph shows the splinting program therapists use over time on average. As you can see, therapists began weaning the splint around 4.5 to 5 weeks. Traditionally, we are taught to splint full-time for 6 weeks, but there are situations when one can wean the splint earlier. As a rule of thumb, I tell my patients that tendons heal at a rate of 1% per day, and when weaning a splint around 5 to 6 weeks, the tendon is only about 40% strong, and therefore there is still the need for caution. In my research, I use traditionally named protocols as a general guide. The flexor tendon protocol trend that I found in the research was 28% used an early active mobilization type protocol, and 25% used a Kleinert type protocol, which is passive flexion active extension. 18.8% used a Duran type passive mobilization protocol, and only 3% immobilized. These are a couple of splints that are options made by myself and a colleague. I'd like to note here that the rupture rates in literature is about 5%, regardless of which protocol one uses, except for the immobilization protocol, which has higher complication rates. Sometimes we are unfortunate enough to receive early referrals, and thus, if the patient has been immobilized for a prolonged period, rehab with caution, as a tendon repair is weaker. So I asked the respondents how they mobilized their patients' fingers, and the results are tabulated in the slide. I was delighted to see few immobilized the fingers, the red line, and once again the transition from passive range of motion in the splint, the dark blue line, and active flexion in the splint, the dark green line, to mobilization out of the splint occurred around 4.5 to 5 weeks. Mobilization of the wrist, however, was slightly different. I think us therapists forget, or perhaps aren't aware, of how beneficial tenodesis glide with wrist action is for encouraging tendon excursion. Immobilization of the wrist, the red line, only reduced after 4.5 weeks. Few therapists mobilize the wrist in the splint, but this is actually a technique I find very easy to do, providing there isn't a solid palmar bar on the splint as demonstrated in a previous photo. You'd need to use a Velcro strap. So, what are the determining factors for protocol or regimen choice? Personal preference. This encouraged me tremendously, as we should be choosing protocols we have the most confidence in. However, doctor requests and departmental protocols can be helpful, especially when one is unfamiliar with various protocols available, and can be helpful for junior therapists. I would encourage each department and practice to have a printed out protocol that therapists can reference should they need to. Sadly, at the time of my research, current research trends didn't seem to play such a big role on our protocol choice. Regular in-service training and physical practicing on colleagues is really helpful to gain confidence. So, if we're not getting our information from current research trends, where are we getting it from? Textbooks. Textbooks are outdated often, even when they go to print. And yet, how many of us still reference the blue, the red, or the yellow Hunter, Macken et al. Rehabilitation of the Hand, which was published in the 1980s, the 90s, and 2002. They are more than 20 years old. But I wouldn't give a book up like that, and I'm sure none of you would. Textbooks are helpful for clear guidelines, especially regarding protocol outlines, but we should keep up to date with new research. Earlier, I mentioned various factors that influence our protocol choice. I also wanted to establish how often which factor had the greatest influence. I was pleased to see that confidence in skill was the highest prevalent factor, even if current research trends were almost lowest in the always category. My suggestion would be to start with a protocol you feel confident in and gradually push your boundaries in hand therapy techniques, ask for help, watch others, and expand your repertoire. I asked the therapists if they would change their protocol choice, and the answer was no. I also asked if they felt their protocol chosen was effective, and they said most of the time. I think we aren't very honest if we say always. Tissues heal differently, and sometimes we just struggle to overcome aggressive scar tissue. But at least in those patients, their tendons are less likely to rupture. Sometimes we also can't control the patients, and we may have a patient who is healing beautifully but needs to be slowed down due to not enough scar tissue. That is why weekly sessions and careful monitoring is so important. So the Cochrane review I mentioned earlier was published recently. Their findings were that there was no significant difference in patient-rated function in terms of early active flexion together with controlled passive exercises compared to just controlled passive exercise group. In other words, outcomes of a type of early active mobilization protocol with a Durand type protocol are roughly the same. There is no significant difference between active exercise regime and an immobilization for 3-week regime in terms of active finger range of motion and adverse events. In South Africa, we often only get patients after 2 to 3 weeks post-op, and functional outcomes are similar in these cases to the patients that we've had the privilege of mobilizing from the first week. There was, however, a significant difference in the place and hold exercises when compared to the passive motion with a rubber band after a year in terms of self-rated function. I haven't used a Kleiner type protocol for many years, but I do still have it in my toolbox of ideas should the need arise. I think we have moved on from these intricate splints that are at risk of breaking to a more patient-empowered early active motion type protocol. We as therapists should not be afraid to ask for help. Hand therapy is an art as well as a science, and I would like to encourage all of us to believe in ourselves. Gaining confidence in your skill through practice and asking questions is a tremendous factor in successful outcomes. Thank you for listening to my talk.
Okay, thank you to Jane. Good. Okay, now you know what works and what doesn't work. Okay, I hope you listen well. Okay, the next one is face-to-face, what do you call it? Yeah, so that's going to be Jenna Cohen. And she's going to talk about the management of upper limb pain in stroke survivors, the current practice of occupational therapists in South Africa. We're hearing a lot of evidence and things that's happening on the ground, so it's great.
Okay. So I must change slides with this. Perfect. Cool. Okay, thank you so much for letting me present today. I'm talking about something a little bit different to the trauma-related hand injuries. So I am currently doing a study on the management of upper limb pain in stroke survivors, and I'm looking at the current practice of OTs in South Africa. And just to acknowledge my supervisors, Fiona and Kirsty. So as an introduction, we know that OTs play an important role in pain management, and evidence also shows that pain is a prevalent complication post-stroke, but it appears as though there is neglect of proactive pain management with regards to prevention, assessment, and treatment. This contrasts with what the research is telling us, as this shows that pain can be managed effectively and ultimately improve quality of life. Stroke survivors have identified with the upper limb as the most common area of pain that they experience after their stroke. However, the current practice of OTs in post-stroke upper limb pain is currently not known. It's important for us to know this so that best practice can be implemented. The study followed a quantitative cross-sectional survey design through an online survey. Content validity was completed, and the survey was distributed through various platforms. From February, so it's a very early study that's just started and is open until around the end of April. Preliminary results were analyzed using descriptive statistics. So These preliminary results include responses from 40 participants so far. And what's important to note is that 55% of the participants were OTs working in private practice, and majority held an undergraduate degree, with 25% holding a postgraduate degree or diploma. Looking at the demographics of stroke patients that were identified by the OTs in the study, they identified with working mainly within a subacute setting, where the largest setting was the largest setting that was identified, and this includes intervention with stroke survivors from 3 weeks to 3 months post-stroke. And majority of strokes are seen in current practice are between the ages of 51 and 60. Physiotherapists were identified as being involved in post-stroke pain management by 97.5% of the participants, and other MDT members that weren't included on the checklist but were identified were speech therapists, music therapists, and dietitian. So looking at this bar graph, it's congruent with the literature. The participants noted that the shoulder is the most common component of the upper limb to present with pain, and the wrist and fingers were identified as the second and third most common components. Sorry, give me 1 second. Only 5% of the participants indicated that stroke survivors they intervene with experienced no pain. So that's indicating to us that this is a relevant problem. Not presented in the graph, but relevant to the study. Sorry, let me just go back. The top 3 descriptions of pain that they identified was shooting, dull, aching, and hyperesthesia, and the most common duration of pain was during passive movement of the hemiplegic upper limb. So this graph shows the percentage frequency of consideration of pain by the OTs in post-stroke, compared to their years of experience of the therapist working within stroke rehab. Only 1 participant indicated to not consider pain after stroke, and the reason was that there are other MDT members focusing on this. Half of the participants indicated to consider pain, but they identified as not intervening in this regard due to not having the skills and knowledge to intervene. This is noteworthy for today's discussion. 40% of the participants have less than 5 years of experience, and a smaller percentage of those with 6 to 10 years and 11 to 20 years of experience also identified with reduced skills and knowledge, so not only junior therapists. Another reason for not intervening in post-stroke pain was not having the time to intervene, and 24% of the participants identified with this as a reason. Majority of the participants with between 11 and 30 years of experience did identify with always considering and including pain in the intervention. Some participants were between 1 and 10 years of experience, also identified with always considering pain post-stroke. Participants were requested to rate the frequency of use of various prevention techniques in their current practice for the prevention of pain in the upper limb, and some of the techniques are shown in the graph. The graph shows that passive range of motion exercises, avoiding traction of the arm, and educating on safe positioning were the most common prevention techniques. Majority of participants never or rarely used strapping or shoulder slings as a preventive technique. The South African Contextualized Stroke Rehabilitation Guideline, which was published in 2019, indicated that avoiding traction of the arm has low positive strength of the body of evidence. Education on safe handling on the hemiplegic upper limb has high positive strength from the body of evidence. However, these principles are mentioned under manual handling and not specifically with regards to pain prevention. Passive range of motion exercises is identified as having low positive strength of the body of evidence, and congruent with the guidelines, shoulder strapping is not recommended to prevent shoulder subluxation, and shoulder slings was not mentioned with regards to prevention. Participants were then requested to rate their frequency of use of various assessments in their current practice for the assessment of pain in the upper limb after stroke, and the graph shows that majority of OTs assess, as some examples, the stroke survivor's understanding of perception of pain, impact on cognition, their needs and priorities, pre-morbid orthopedic conditions, standing and sitting posture, location and intensity of pain, and lastly, the impact of pain on an individual's performance in occupations. But many OTs do not assess psychological factors or a caregiver's understanding and perception of a stroke survivor's pain, for example. So the question here is raised is, are we using a biopsychosocial approach, or are we still stuck with the biomedical approach? Lastly, participants were requested to rate their frequency of use of various treatment techniques, and the graph shows that the most common treatment techniques, such as hands-on techniques, including scapular mobilization, range of motion, massage, gentle stretching and mobilization, were used, and graded motor imagery, just as an example, is the least used technique. The stroke guidelines do not mention many pain treatment techniques, and OT-specific techniques are quite limited. So with regards to recommendation, we can see that overall pain is one of the most common complaints by stroke survivors, but it's not being prioritized, and current interventions are rudimentary. So therefore, I recommend that prevention, assessment, and treatment of post-stroke pain be included or strengthened if it is currently included in undergraduate and postgraduate training. Also, developing OT-specific stroke guidelines that include pain, running workshops and courses on post-stroke pain, particularly for community service therapists or more junior therapists, as those with fewer years' experience identified with limited skills and knowledge in this regard. And OTs also need to use best evidence and prioritize post-stroke pain and intervention within their practice. Thank you.
Okay, thank you, Jenna, for bringing this to our attention, and good luck with the rest of the study. So the next one is also a live presentation. So that is Monique Keller and Rolene Barnes. And Monique is a physio. She's not an OT. And she's going to talk on splints and immobilization approaches used for second to fifth metacarpal fractures, a systematic review. Thank you.
Thank you. I'm doing someone else's talk, so I'm going to... okay, now. Good afternoon, everyone here and joining online. It is a privilege to be here. I feel very short standing here. And Kirsty, well done for dreaming this up, and to your supervisors for assisting you up to this point. This is really special. So when I sat... okay, yeah, there's my presentation. So my time hasn't started yet, no, Dalian? Not yet, all right. So when I was in my first assessors meeting at the Free State, you'll see I'm a WITS lecturer, and I studied at the Free State because I started while I was working at Barra Hand Unit. And they said to me, but why splinting? And I said, because the OTs also want to know. And that is why I'm presenting this here, because we have to base our clinical practice on best evidence, right? Okay. So this is part of my PhD. That's almost finished. And you will see how it fits in. It's the first phase of 3. And then the second phase was a cross-sectional study where we added scientific testing with 4 sensor resistors of 105 activities of daily living to inform the return to light, moderate, and heavy function, so we can guide them better to what to start, maybe not mowing the lawn when you do light activities, for example. And then the Delphi method, where we included 14 experts, hand surgeons, occupational and physiotherapists. So what I'm presenting to you today is the first part, but also backed by the expert opinion, because that's where I had challenges, because what is in literature is not always what is used because of the variability of the type of fractures, the associated injuries. So just also to note that one size doesn't fit all. You can't use this for any type of boxes fracture, right? Clinical reasoning is important, and that is what the trick is, how we're going to teach that for OTs, physios leaving the varsity and now having to deal with office skill in limited resources while they have to clinically reason. Right. Dalian, my time is starting now, nah? So, the problem is no best evidence splinting or immobilization programs are there to inform clinical practice, nationally or internationally, and this affects the young working population, so grip strength, range of motion, and also because of the trauma that we find in South Africa. So the systematic review question was, what evidence is available for conservative and post-surgical splints and immobilization approaches utilized, including but not limited to plaster of Paris and or splints, as part of initial management for adults older than 20 to 59 years of age, reporting on outcomes which include but not limited to hand function, health-related quality of life, disability, digital range of motion, grip strength, fine motor dexterity after sustaining single or multiple second to fifth metacarpal fractures. Here are the methods, and you will see that Prisma guided the reporting. The trial is registered with Prospero. 2 reviewers independently screened, selected, appraised, and extracted data from the included studies. That's why Lauren, my OT friend from Free State, was part of this. And we included studies from January 2008 to September 2018. English language, our inclusion of studies, you can see there, as well as our exclusion criteria, to note carefully what we excluded. So what did we find? Our results, we found 1,005 articles through the database searches, 10 additional articles on a Google search, and after carefully putting those through, we had to exclude due to pediatric studies, language, and other reasons. And we found 10 articles that we included. No meta-analysis could be done, but a descriptive reporting that you can find as a peer review article in the Journal of Occupational Surgery. So now I'm going to present the results. So you will see the first is for all metacarpal fracture types, and this was a study done by Gulke et al. 2018, a German team, and they did a prospective cohort randomized controlled trial of high-grade quality of evidence rating, and they used this splint. Okay. The splint is a forearm-based dorsal wrist extension splint that places the MPJs in 70 degrees of flexion, and you can clearly see that function is allowed early on. Why did they do this? They ascertained the effectiveness between traditional physiotherapy compared to home exercises in 60 individuals. So they kept this splint on for 2 weeks, and after that they started with either their home exercises or their traditional physiotherapy. What they found after 12 weeks was, in both groups, good grip strength as well as TAM, digital total active motion. So they concluded from their results that both a home exercise program and traditional physiotherapy were both effective in the post-operative management with this regime. So this is potentially how home exercise programs can be used where waiting times are long in clinics. Okay, so that was for all types of metacarpal fracture: base, neck, shaft, or head. All right. Now we're going to go a little bit more specific into different types as well. The neck of the second to the fourth metacarpal fracture. You will see here that after stable surgical fixation with an ORIF, a hand-based dorsal gutter splint with the affected and adjacent finger, MPJs in 70 degrees of flexion, the wrist and IPJs free to move and to use. Right. For 2 weeks. Same splint was found, and you'll see Meatley and Tuman that we saw with the Sims as well. they found this. Okay, so with surgery, less time, 2 weeks, but remember that we can't then just discard the splint. It's a gradual weaning period. Conservative management, we keep the splint on for 4 weeks. All right. Okay, we're going to go on to the next. I just want to see if I'm missing something. All right, and here the experts said, after mobilization after a stable RF, initiate immediate early active motion 2 to 3 days post-surgery. And that is if it's stable. All right, then we're going to go on to the boxes, the neck of the 5th metacarpal fracture. And here a study was conducted by Van Aken et al. 2016, a randomized multi-center trial on 68 participants who sustained boxes fractures. But to note, with less than 70 degrees of angulation and no rotational deformity, a high-grade quality of evidence level is found in this study. So what they used was very interesting. The one group that they randomized, they used this soft wrap and buddy strapping for 3 weeks. The other group, they did a reduction in immobilization of forearm wrist POP, forearm wrist extension POP to the PIPJs with metacarpals in extension for 4 weeks. So what did they find with these two very different approaches? Significantly, this management, their patients returned to work 11 days earlier. So that is important for our people wanting to return to work and wanting to earn an income. All right. No statistical significant difference was found for outcome measures, quick dash, pain, MPJ range of motion, grip strength, and aesthetic appearance. So the experts also said that after stable RF, for boxes fracture, they are generally impacted and therefore stable. Splinting is just for comfort and the fractures are unlikely to be displaced. Right. Now we're moving through the different types. Still the head of the 2nd to the 5th metacarpal fracture. Here also a hand-based dorsal hood gutter splint with the affected and adjacent finger MPJs in 70 degrees of flexion, the wrist and all the IPJs, and unaffected MPJs left free. This is for after surgical with an RF 2 weeks, and for conservative management or KYs for 4 weeks. And please remember and note that if there's KYs used for intervention, that the splint needs to be kept on while the KY is in, and the splint needs to respect where the KYs are angling. Right. Just making sure I'm not missing anything. Right. Generally, all our experts said, okay, start immobilization after stable RF from as earlier than 2 weeks, even 2 to 3 days. I see Dalian is coming closer, so I must wrap up. Okay, base, almost there, almost there. You will recognize the splint also. Forearm-based wrist extension splint, 20 degrees of extension, MPJs, IPJs left free, so the fingers can move. Okay, shaft fractures. Again, Meatley and Tuman suggested after surgery that a sandwich splint can be used, like you can see there. Also for after surgery, for 2 weeks, conservative management, 4 weeks. All right. And initiate, our experts said, also initiate early active motion from 2 to 3 days after surgery and the involved MPJ to prevent adhesions. So developing, with this research, developing a clinical hand rehabilitation guideline can assist our generalist therapists, but how are we going to guide that clinical practice and careful assessment? I leave that to you. Thank you very much for your attention.
Thank you, Monique. So that was also very specific information for you to take home, and I hope that was useful. So now we have an online one again. So that is the evidence-informed recommendations to support best practice for work-related transitions after hand injury, a strategy to improve rehabilitation and outcomes. And that is by Helen Buchanan and Lana van Niekerk and Karen Grimmer. Thank you.
Good afternoon, everyone. It's my real privilege to be able to present at this Consensus Development Conference this afternoon. I'm presenting on behalf of my co-researchers, Lana van Niekerk and Karen Grimmer, and I'm Helen Buchanan. This study is the third part of a 3-year study, and we developed evidence-informed recommendations to support best practice for return to work after hand injury. And my question here is this a possible strategy to improve rehabilitation outcomes? The study was funded by the National Research Foundation, and I would like to acknowledge them for their generous funding of the research. So to start off with some background, firstly, successful participation in work is an important outcome following hand injury. Poorly managed, even relatively minor hand injuries can interfere with a person's capacity to manage day-to-day activities and to be gainfully employed. Secondly, the process of transitioning to work can be complex, especially where access to rehabilitation is limited and therapist time and expertise is lacking. Thirdly, timely access to evidence-based health care, including rehab, is essential to optimize recovery. And fourthly, care following hand injuries has been reported to be inadequate in many parts of the world, particularly in low and middle income countries, where up to 50% of people who sustain an injury do not receive any health care, let alone rehabilitation. So at the time of this study, there were no existing clinical practice guidelines to guide the return to work process after hand injuries. And it's really important for novice OTs or generalist OTs who don't have experience in working with people with hand injuries to have this kind of guidance, particularly where they have limited support or expertise available. So the aim of this study was to develop evidence-informed recommendations to support successful work transitions following hand injuries. And our target users were occupational therapists involved in supporting people with the return to work process. We followed Schoenemann et al.'s guideline development process, as well as the 3-tier clinical practice guideline model developed by Machin-Gaidzi et al. Our recommendations were built on 4 sources of data. The first, in the top left, were narrative interviews that were conducted with expert OTs in the public sector as well as private practice on current occupational therapy practice. The second, top right, were expert-informed clinical practice directives which built on the interview findings and were mapped to a usual care pathway of clinical decision-making in South African healthcare contexts. Thirdly, bottom left, were client and therapist perspectives of barriers to successful work transitions. And then lastly, was current best evidence that was extracted from a systematic evidence scan of the literature. So this was a scoping review that has actually been published. And we used Hillier et al.'s approach to link the evidence to each recommendation, and I'll show you that a little bit later. So we followed this approach to developing the guideline, and these are the steps in Schoenemann et al.'s guideline process, although we followed them in a slightly different order. So the first was because there was no evidence available for practice in South Africa, we actually started by interviewing experts to help us develop the clinical questions we wanted to explore, as well as practice context and keywords for the searches. Part of this then also was looking at typical patient care pathways based on information from these interviews, as well as our knowledge as the research team about patients undergoing rehab and treatment following hand injuries, as well as employment and healthcare systems. The second step was to do a comprehensive search for all literature informing any aspect of return to work following hand injury. And then step 3, to then critique this literature and look at the strength of the evidence, following which we started drafting the recommendations. So this required interpreting the evidence as answers to the clinical questions, as well as identifying what we call how to do it tools, which I'll explain a little bit later. And then fifthly is to look at implementation plans. So this is looking at barriers and facilitators to uptake, as well as implementation plans and audit criteria to look at the effectiveness of the guideline. So we followed the 3-step clinical practice guideline model, as I've already mentioned. So in this model, Tier 1 is the available body of evidence, which was sourced through rigorous literature search, as well as critical appraisal and synthesis. Tier 2 is the expert input into the formulation of the evidence search questions, as well as commentary on the feasibility and contextual interpretation of the evidence identified during the Tier 1 process. And then step 3 are what we call the how to do it documents. So these are end user documents which help therapists to be able to put the evidence into practice, and these can range from anything from protocols to templates for note taking to summaries, etc. So the recommendations are linked to 3 phases of rehabilitation. So the first being the acute phase, which is in the first 7 days of seeing the patient. And you'll see here that the recommendations, there's 7 recommendations here, and the strength of the evidence varies from B to C, with A being the strongest level of evidence. And you'll see also where the evidence gap lies. So when it comes to communication with or educating the employer, there is no evidence available on that. So each of these recommendations would be accompanied by the Tier 3 documents, which would lead therapists through knowing, for example, what a thorough assessment would look like, what assessment tools to use, and so on. The second phase is intermediate, and that's from 1 week to 12 weeks after the injury. And here what you will see is there are 2 recommendations that pull through from the acute stage. So that's intermediate 2 and 3. So the 2 and 3 relate to recommendation 2 and 3 from the acute phase. And then there are 4 new recommendations, and they relate to things like self-efficacy, self-advocacy, home rehab programs, and so on. And then for number 10, which is about the transition to work process, there's some recommendations that fall underneath that. The third phase of rehab, the longer term phase, is 12 weeks plus. And here you'll see all the recommendations pull through from the acute phase and the intermediate phase. Then other recommendations pertain to the entire rehab process, from when the patient starts being seen until they are successfully back at work. And these recommendations are essentially about practice improvement. And again, they vary. So some of them are about templates for communicating with stakeholders, and then other things like recording outcome measures and supporting the family, which applies throughout. This guideline is, to our knowledge, the first composite evidence-based list of recommendations that have been developed to assist occupational therapists to undertake effective strategies for returning hand-injured people to work. The recommendations were developed to be contextually relevant and feasible for implementation within the South African public health sector. We think that they'll prove useful in guiding novice occupational therapists to implement effective strategies for the transition to work process for people with hand injuries, and we hope that the recommendations will contribute to improving rehab outcomes and work-related outcomes after hand injuries. Thank you for listening to my presentation, and I'm more than happy to answer questions or to have discussion on this.
Thank you to Helen. So please remember your sticky notes to still make your own recommendations for strategies for training. Okay. Can you organize your sticky notes like that? Yeah. All right. Thank you. Okay, so the next one is innovative options for edema reduction in hand injuries, and Susie Davies can do that. So here's just forward.
Okay. Good afternoon. Thank you so much for having me speak today. I'm very excited to be sharing hopefully some novel information. If you haven't been exposed to lymphatic drainage and the wonders of manual lymph drainage, I'm excited to be presenting on this topic with innovative approaches for edema reduction. But I know I'm the last talk before our break, so I think the best way to show you how lymphatic fluid moves in the body is to stand up and get a little bit of hand therapy stretching, right? That's the best way, because this is the muscle contraction is how lymph moves throughout the body. So well done. You guys can have a seat. Good. Do I point it here? Oh, okay. Great. So how to reduce hand swelling? Well, you don't know what you don't know, but once you do know, then you must do better. And I think this is definitely a cornerstone of hopefully all hand therapists, all lymphedema, all occupational therapists, and any community service therapists that are working in the field. Hopefully we'll be able to educate more of them. So the objectives is to reduce edema effectively in hand therapy treatment. Could possibly include incorporating manual lymph drainage techniques and to teach patients some self-lymphatic drainage. Of course, everyone knows range of motion exercises, but we've been incorporating in the lymphatic rehabilitation field to utilizing stress ball to stimulate lymphatic flow in the lymph node areas, which would then facilitate reduction of edema. Then, of course, elastic taping, short stretch compression bandaging with foam padded inserts, and compression garments, whether those are going to be ready to wear and custom when pressure garment material is not effective enough for those patients that are struggling with edema. And then we'll touch upon quickly, because I've only got 10 minutes, on types of compression. And for help with edema, there are certified lymphedema therapists all throughout South Africa, and 2 websites where you can find a therapist would be lymphafrica.com and LEOSA, which is the Lymphedema Association of South Africa. So hand edema, varying types of edema. This is something that all of you see probably every single day. But we're going to go back to anatomy and physiology and the blood circulation. So you know the heart pumps the blood through the body, the veins, the arteries move the blood away, the veins move the blood back, but then there's the lymphatic system. It's what picks up the excess fluid in the interstitium and brings it back to the venous system. So the blood and lymph vessel system, as we've just mentioned, it reabsorbs the fluid of the interstitial spaces. So Starling's law was introduced in 1894. We used to think that 90% of the blood that was filtered in the capillary bed was reabsorbed by the venous system, and only 10% was reabsorbed by the lymphatic system. But now we know that there's a new paradigm of microcirculation, and we now know how important the lymphatic system is, and we know that now 0% of the interstitial fluid is reabsorbed back into the venous end of the capillaries, and that we now know that a lymphatic system manages 100% of fluid reuptake from the capillary bed, from the interstitial spaces. So if edema is not reducing within a 6-month period with rest, ice, compression, and elevation, then consider it is a failure of the lymphatic system. And all fluid and proteins must be removed from the interstitium by the lymphatic capillaries alone. Therefore, the new research is stating that all edemas are on a lymphedema continuum. And just note that when you're not reducing that edema effectively, if there's a protein-rich edema that is not being reduced, at some point you can actually call that a lymphedema, and it's not just swelling anymore, it's not just edema. So in Mortimer and Roxon are two big names in the lymphatic field, Mortimer from the UK and Roxon is from the University of Stanford in America. But they've quoted, arguably it may be better to consider the presence of chronic edema as synonymous with the presence of lymphedema, inasmuch as all edema represents a relative lymph drainage failure. So there is lymphatic dermopathy. So again, seeing patients such as this, lymphatic failure produces a cutaneous region susceptible to infection, inflammation, and carcinogenesis. And localized lymphatic failure causes disruption of adaptive immunity, lymphatic dermopathy, which is a failure of the skin as an immune organ. So treatment, and we'll touch upon quickly on this. Manual lymph drainage, it's slow, gentle, and rhythmic. The focus of MLD is on decongesting edema, and it's basically through several techniques where stretching of the skin, there's a relaxation phase, an active phase, and a relaxation phase. And again, we're not going to go into the details of that today, but treatment is always proximal to distal. So we don't do retrograde massage with lymphatic drainage. It's treating the lymphatics, the lymph node areas, light manual stretching and releasing of the skin. It's not massage. It's a semicircular movement towards the healthy lymph node areas. Of course, exercise is always incorporated. When there's edema, we always recommend having bandages or compression garments in place, and 5 to 6 repetitions per day of whatever exercises, and specifically to the lymph node areas. Lymph drainage is not something that can occur once a day. It should be a few times a day to stimulate the lymphatics to actually start working more effectively. Elastic taping is a fantastic modality. For those of you who are not using elastic taping, I can't stress enough how effective it is with edema reduction, and a variety of different techniques. And then compression bandages. So in lymphedema, when it is a lymphedema, short stretch compression bandages, again, we wrap the fingers with a conforming bandage. We use cotton padding, foam padding, different types of uneven foams, and then short stretch bandages, either in the 6 or 8 centimeter, applied in specific ways to ensure a gradient compression. Of course, nutrition and diet is a super important aspect to edema reduction as well. Increasing water intake, decreasing sodium in foods, decreasing processed foods. I think I ate too much sodium at lunch. That was a sip of water. But also increasing natural fresh foods. So the case for compression, excuse me. So compression improves circulation and maximizes venous return, improves volume and rate, and reduces capillary ultrafiltration. Compression also improves lymphatic circulation by maximizing lymphatic function, increases lymph reabsorption, stimulates the lymph angion contractions, reduces inflammation and pitting edema, and promotes wound healing and breaks down hard fibrotic tissue. So there's different types of compression categories, and I think this is something in the hand therapy world. I find that those pressure garment material, it's an interesting dynamic. In America, I didn't use pressure garments. We don't learn to sew as OTs in the States. I have been living here for over 10 years in South Africa and absolutely love it. But the types of compression categories is really important to understand and utilize all the different aspects when edema is not being reduced, to recognize when whatever compression you're using is not effective, to try another type. So ready to wear and graduated compression garment categories start with circular knit, which would be the basic pressure garment material. Then there's stiffer circular knits, flat knit material, Velcro wraps, foam night garments, and then the decongestive bandaging. But lower stiffness, such as with pressure garments, does not equal easier to don and doff, but it does equal lower containment. So testing for pitting edema, how long do you guys press when you're testing for pitting edema? 10 seconds, 30 seconds, a minute? Well, at least 30 seconds is important. And to really quantify the amount of pitting edema that is in a patient, recognizing how much protein-rich edema is there. So containment is the ability of a compression garment or product to prevent the expansion of edema and to maintain the ideal shape of a limb after therapeutic decongestion. So pressure garments, although it is the norm here, I took a pressure garment sewing course whilst here in Cape Town, and it's time-consuming to sew. It may not provide the appropriate or correct level of pressure at adequate containment. The quality of compression material is only guaranteed for a few weeks, maybe a few months, and patients need to return frequently to adjust and make new garments, which was one of several presentations. I know yours was one, is that it's time-consuming for patients. They have to travel long distances, and they may have to return every 2 months to have a pressure garment made. Whereas getting a compression garment that's ready to wear, whether circular knit or flat knit, which these compression garments are on government tenders, and patients can even get them in the government sector as well as in the private sector. It's actually more cost effective for patients to be fitted for a proper compression garment that will last them for 6 months. It doesn't require them to keep coming back every 2 months to have them readjusted. So it's something to consider. There's also different types of foam wraps and Velcro wraps. Thank you very much. Thank you.
Okay, thank you so much to Susie. I think there was also some good practical tips. So even I understood this presentation, so thank you. Okay, so now it's time for questions from this session. So any questions for a particular presentation? Well, most of them were online, so no questions on that. So let's move on to comments. Any comments? Yes.
This is a general question about SASA and UIF. I've tried to approach them for data to see how much of what they get is from hand injuries, but it's like a wall. I just can't speak to anybody there or nothing, and it seems to me like a perfect place to collect this type of data from.
Where is that?
SASA, for disability grant.
Oh, SASA.
SASA, yeah.
Oh, okay, well, you're speaking to the right person. We are doing work for them, research for them. Yeah, maybe you can I will talk to you, your specific query, so that we can access the data.
Just on CRPS, it's the opposite almost. So with a bit of private patients that I see, it's almost impossible in private to get them treated in KwaZulu-Natal. It's just not worth anybody's time to treat these patients. I think you get some anesthetists that would do some blocks that they can charge for, but it seems like nobody wants to spend time with these patients. It's just too much effort for the amount of reimbursement that you get in private. So it's more of a problem in private than in public. In public, we've got a good pain center where there's people that interested in it. But
okay. Similar experiences? Okay. Don't think to be an answer to that one. Okay, other comments? Thank you. Did you listen to the presentations? Okay, I think it was also quite informative. Specific conditions, a lot of suggestions there, and maybe some things that we can take forward to our consensus on the strategies that we will do tomorrow. Okay, so I think then we can have tea, and you must please be back by 15:30. And then after the last session, we are going to start with an invited presentation. So I'm looking forward to that. Right, see you then 15:30.